Boy oh boy, do I love my KFC. Something else I love, I've been doing it since I was 12 years old, smoking cigarettes. Oh!
What happened?
Hi Nick, I'm Dr. Kuhn. I'm your attending physician. This is Dr. Hume. She's here on your treatment team as well as a cardiologist specialist. And this is Edith, our pharmacist, and Tony, her resident. How are you feeling today?
Not so good, Doc.
That is reasonable considering the circumstances. I know this isn't your first time being here at Presby for a heart attack. We really want to try to prevent another one because each time this happens, you take significant time off your life. We were able to place a stent when you came in to return blood flow to your heart. But Edith is going to talk to you a little bit about your medication so we can try and prevent this from happening again.
Hi Nick, my name's Edith. I'm your pharmacist. This is our PD1 to a cardiologist resident, Tony, and he will give you a brief introduction about your case.
So Nick is a 45-year-old white male presenting after a stent placement for his third end STEMI. Has a past medical history of CAD, PAD, hypertension, hyperlipidemia. Has had 2 end STEMIs in the past 5 years with stent placements both times.
Nick, we would like to create a medication regimen for you to go home on. I will recommend 10 milligrams of lisinopril by mouth daily, 81 milligrams of aspirin by mouth daily, 25 milligrams of metoprolol succinate by mouth daily, 40 milligrams of atorvastatin by mouth daily.
Alright, so our options for antiplatelet therapy are aspirin and clopidogrel, or aspirin and clopidogrel and Vorapaxar. What do you guys think?
I think we have to go with 2.5 milligrams of Vorapaxar daily in addition. It seems like we worked pretty well from recent trials and it was recently approved, so I'm eager to try it out.
I heard Vorapaxar is the first PAR1 inhibitor approved by the United States Food and Drug Administration in coronary and peripheral vascular disease in May 2014. I think it works by inhibiting PAR1, which would normally bind to thrombin and then to other platelets to form a thrombus. But this works by taking the active site and binding to the part of the protein embedded in the membrane. What do you think, Edith?
Vorapaxar is a protease-activated receptor 1 antagonist indicated for the reduction of thrombotic cardiovascular events in patients with a history of myocardial infarction or with peripheral arterial disease. What do you think about this drug, Tony?
Hold on, I was just in a journal club and I heard some bad things about Vorapaxar. In the TRAP2 TIMI 50 trial, it was proven to not decrease CV events in patients with PAD, but it did increase the risk of bleeding.
Well, Vorapaxar was approved after the results of thrombin receptor antagonists in secondary prevention of atherosclerotic ischemic events, thrombolysis, and myocardial infarction. 50 trials were released. The results revealed that Vorapaxar reduced the rate of the combined endpoints of cardiovascular death, myocardial infarction, stroke, and urgent coronary revascularization when we used along with aspirin and or clopidogrel in patients without the previous history of stroke. The TRAP2 TIMI 50 trials show that the inhibition of PAR1 with Vorapaxar reduced the risk of cardiovascular death or ischemic events in patients with stable atherosclerosis who were receiving standard therapy. However, it increased the risk of moderate or severe bleeding, including intracranial hemorrhage.
Vorapaxar has a very long half-life and it's effectively irreversible. Vorapaxar irreversibly binds to the PAR1 receptor with a long receptor dissociation half-life of approximately 20 hours. Additionally, Vorapaxar displays significant inhibition of platelet aggregation that remains for up to 4 weeks after discontinuation due to the very long elimination half-life. There is no antidote for Vorapaxar, which means that it will be hard to reverse a severe bleeding event. If he starts bleeding, it's going to potentially kill him. We wouldn't set off fireworks without first responders nearby, so I don't think we can in good faith give this if all it could potentially do is harm him.
This is the patient's third end STEMI. We need to do something besides the normal dual antiplatelet therapy. I don't want this to happen again. Since he has no history of TIA, stroke, or intracranial hemorrhage, he is not contraindicated to this therapy. This is exactly the candidate we'd use for this drug.
We can't consciously put a patient on a drug that might just hurt him without any benefits, regardless of how high risk he is. He needs to have lifestyle changes, and we need to ensure he is even taking his 2 antiplatelets like he is supposed to. Edith, what do you think?
Vorapaxar inhibits the PAR1 pathway, which is the pathway that is not targeted by aspirin or clopidogrel. Vorapaxar should be used with daily aspirin and or clopidogrel according to the indication and has shown to decrease the risk of CV events, However, Vorapaxar increases the risk of bleeding, including life-threatening and fatal bleeding. We need to make sure the risk is worth the benefit.
Population data doesn't always apply to the individual. We would be doing this patient a disservice if we didn't try everything we can to prevent this from happening again.
His antiplatelet therapy isn't the problem. His lifestyle all but guarantees this happens again. This risk is not worth the benefit in this case.
Well, what do we do here then? Tell him to lay off the smoking? Don't you think he's been told that before? That stuff is fine, but we need this therapy for him. He's exactly who we're looking for to try this in.
I just don't feel comfortable giving him this medication, and I think it would be irresponsible of us to prescribe it. Me and Edith will talk to him about some lifestyle modifications. At this point, changes in his drug regimen won't really help him.
Wow, you 3 doctors must be really good because I'm feeling a lot better. When do I get to go home?
We'll get you home soon here, Nick. So the treatment team and I were talking about maybe adding another medication to your regimen. It's called Vorapaxar. It'd help thin your blood a little bit. We decided not to go with it though because it's going to increase your risk for bleeding a lot and not really have any benefit to you potentially.
Oh.
Yeah. So Edith is going to talk to you a little bit about some stuff we can do to maybe lower your risk for this happening again, because we really don't want to see you back here at the hospital for this for a 4th time.
So Nick, before we send you home, we need to talk about what caused your heart attacks in the first place. What do you think is causing these heart attacks?
Well, to be honest, Doc, I really don't know. Aren't you the experts in medication?
We do have you on a lot of the medications. That is true, but with your conditions, all these medications are necessary. If you want to live longer, medications can only help you so much. If you make some modifications in your diet, I think it might help you in the long way.
Like maybe laying off the Big Macs and Crunchwrap Supremes?
Exactly right. And smoking is also increasing your risk.
I know that stuff is bad for me, but it's so ingrained in who I am. It would be so hard for me to quit.
Well, I have some pharmacist friends in the community that can help people with trying to find a good balance between lifestyle modification and your drug therapies. They can help you out quit smoking and create a great diet plan.
That sounds awesome. Thank you all so much. I am really going to change for the better because of this huge wake-up call. That sounds awesome. Thank you all so much. I'm really going to change for the better because of this huge wake-up call. You're the best doctor ever.
Thanks, buddy, and we're going to get you out and ready for discharge here soon. We'll get you home, and hopefully we won't see you again for a very long time.